Health is a state of body and mind. Wellness is a state of being. We want you to have both. This is Channels of Health, the podcast giving you ideas and insights into new and time-tested avenues to health. From mental wellness and innovations in mental health to our daily lives and overall health journeys. Join your hosts, Patti and Damian, both founders of organizations dedicated to healing, as they bring candid conversations and new information to you. Let's start the show. Here are your hosts, Patti and Damian.
Kimberly, we like to call you Kim. So happy to have you here today on Channels of Health, along with myself and co-producer Damian Skinner.
Hello, hello.
Hello, thank you for having me.
We are really excited. You have such a great background and you're such a professional in the field. We're going to get right to it. Kim, would you share a little bit about, or as much as you want actually, about your personal story as it relates to the world of eating disorders?
Yeah, absolutely. It's something that is formative to my work. And it's something also that I think more professionals need to be comfortable talking about, because it, more than anything else, patients and families are able to say, well, wow, if Dr. Kim can talk about having had an eating disorder and recovering, like maybe it's not such a bad thing for us to be talking about and making speakable, and it decreases shame and it decreases stigma. And those are still two huge barriers to people accessing good care. So my story, I've been recovered from bulimia and alcoholism for 20 years.
Wow.
And I grew up with a lot of trauma in my family. My father was very sick with alcoholism. We were poor. And, I experienced physical abuse. I witnessed a lot of physical abuse. And there was also sexual abuse in my family system. And how I coped with that stuff. My father, who I was very close to, passed away when I was 11. And that really shook my world. We were raised in the church, and I believed in God. When I would pray, I had spiritual experiences in my faith growing up. And that also was very important to me, because I think it set me up in my recovery to reconnect with something that I actually had experience with. But after my father died, my faith just sort of went away, because he was, my whole world sort of fell apart, because he and I were very, very close. And I sort of coped with all of this by excelling academically and excelling athletically. And that was all very, very good for me. I came into the world, I believe, with gifts, and some of those were intelligence and athleticism. And, that saved me, I think, and helped me have a place within myself that I felt resilience, and that I felt strength, and that I felt esteem. But it was a very lonely adolescence for me, because I really just focused on school and sports. I didn't really have any eating disorder thoughts or behaviors or anything like that until athletic director in my junior year of high school made a comment about my body. And that just it just hit. It hit inside. It wasn't something that I ruminated about. It wasn't something that even on a conscious level I was aware really changed anything for me, but that's just something that sort of stuck with me. It wasn't until college until I started experiencing eating disorder behaviors. And it was kind of by happenstance. And a lot of it for me was getting to college. I mean, but right before college, I tore a ligament in my knee. And I think that's a significant part of my story as an athlete as well. Because that, like I said, was one of the things that I felt like, okay, this is a gift from God. And now this has been, my athleticism has taken a hit. And my faith sort of took another hit. And then I launched into college. I was being heavily recruited for Division I basketball, and ended up getting some offers in Division I, but not the caliber of basketball school that I had been recruited for. But ended up going to the University of Chicago, partially on an academic scholarship. I played basketball there, but it was Division III. So I felt like a loser, like what kind of person plays basketball in a Division III school? So, I got to college and I felt really, really, really out of place, because many of the other kids in my head, comparison is a really dangerous thing for people with eating disorders or people who have susceptibility to it. Because these were kids who had mothers and fathers who were doctors and lawyers and professors. And, my dad didn't finish high school. And my mom did finish high school, but she didn't go to college, So I felt very different from all of these other people, and ill-equipped socially. I had a lot of social anxiety and a lot of fear that was not at all processed or touched. And all of that stuff fueled my eating disorder. So my, the pattern of binging and then purging, which I just sort of stumbled on by happenstance. But once that happened for me, it was like something like flipped in my head that I could not put back. And it took me about 10 years. Wow. To be able to recover, and it got worse and worse and worse over time. And I was like rocking it academically at the University of Chicago, getting all A's, playing basketball, playing softball, got into medical school early, at the beginning of my sophomore year of college. And the first time I, ever sought help, I didn't tell anybody about this ever. Nobody knew about this. And I had so much shame about it too. The shame and the secrecy and the silence was, and that stuff is deadly, and that stuff keeps people from getting help. And I sought help at the Student Counseling Center, which, I was at the University of Chicago. The University of Chicago is one of the few academic centers that actually has an eating disorder program, led by, at that time, it was led by Daniel LaGrange, who is a world-renowned eating disorder researcher.
Yeah, we talked about that.
That's crazy.
Yeah, yep. And I got, I think, 4 sessions at the Student Counseling Center with someone who was like, it's not that bad yet. And
what a comment. Let's wait until it gets really bad enough to put you in a hospital. Sorry.
You only get like 8 sessions here anyways, so we can refer you to someone in the community. But I was like, okay, it's not that bad yet. Maybe I'm, I was symptomatic probably, at that point 4 times a week or 5 times a week.
It's amazing that 4 or 5 times a week isn't that bad.
What's the measurement of that bad in that world?
Yeah. I mean, that's a great question, right? It felt pretty bad to me.
No,
it felt like, what is this thing that's creeping into my life that I can't stop?
Right.
I know there's more to your story, but can we take just a moment and talk a minute about the origins of this? Because I know that people that I have known throughout the last 15 or 20 years who have battled with an eating disorder, they don't talk about it just like stumbling on it by happenstance or it happening to them. Do you have a way of talking about the origins of an eating disorder? I'm sure that it's quite varied, actually. But can you give us any clarity around people are often saying, oh, it's social media, oh, it's peer pressure, oh, it's vanity. And of course, that sort of speaks to anorexia a little bit more than bulimia. But, and I don't want to take you totally off your track. We'll get back onto that story. But the origins of eating disorders, do you have some wisdom about that?
Yeah, so this too is a very important question, and one that's pressing for sufferers and their families, because oftentimes the person feels like it's something they did wrong. A family feels like there must be something we did wrong. And it's multifactorial, we know that. I think, different factors weigh in more with some people than others. We know that there's a genetic underpinning. That is a for sure, right? That's one of the few for sures that we know about eating disorders. Cynthia Bulick and her group in North Carolina have done a lot of work to substantiate that. We know that there are environmental factors. The genetics load the gun, and the environmental factors pull the trigger.
Right.
And many times that can be trauma, that can be media, that can be a lot of times related to other stressors in life. Some of it is psychological makeup of a person, perfectionism. Some of it is cognitive style. Some people come into the world with a more rigid, anxious predisposition. That is some of what pulls the trigger for a lot of people. So it's multifactorial, and this too speaks to why it's so important when we are assessing people with eating disorders that we assess them as individuals with an individual genetic makeup and an individual life experience. There are many commonalities between people who have eating disorders, and we focus a lot on those. But there are also a lot of unique aspects to each and every person who gets labeled with whatever the eating disorder diagnosis is.
Great. That's really very helpful, because I think there's tremendous confusion still about it just being stubborn or lack of discipline or willpower.
Seeking attention.
Yeah, there's all
attention seeking.
Yeah, and they want to almost label people that struggle and battle with this as weak-willed and just get over it type of a thing. And I think it's really important that you go through that. So do you remember where you left off on your story? Because I don't want to have you not complete your journey there.
I will remember, but one more important thing, these are brain diseases. People's brains are hijacked. So it's not a matter of, even people with anorexia, right, which we think of as, well, this is something that gets applauded in society. People lose weight and everybody likes it. So we refer to that as an egosyntonic eating disorder. It feeds the ego. Even people with anorexia are able to say in the depths of their disease, I can't stop doing this. There's something in my brain that just is relentless and I can't stop it. Which is very different than they're just doing it because they want to be skinny, or they're just doing it because they need attention, or whatever else people who don't have eating disorders say about people who have eating disorders.
Yeah, that's right. And since you mentioned the point about the brain, a lot of people don't understand that your brain is an organ, and as you are starving your body, you are starving your brain, and your brain is lacking the capacity to tell you to eat. People can't comprehend that it's not something that you're doing intentionally, but that it is literally a functional problem that your brain isn't telling you that you have to eat.
Right.
Yeah. In fact, it's telling you must not eat.
That's interesting. Yeah, it's actually saying the opposite. That's a real good point.
Yeah.
Yeah.
You're gonna that food is gonna harm you, maybe even kill you. The food is not good for you. The food is not your nutrition.
It's like that survival instinct has switched, and it just stays on when it's not necessary. And it's frustrating for people who, you work in other backgrounds. I've worked in other backgrounds where people have physical you can see what they're struggling with. And there's more empathy, there's more understanding. I explain this to my children. You can see this person is struggling. Yeah. So there's empathy there. You don't know that these people are struggling, but once we educate people that they're struggling, there still seems to be a lack of empathy because there's not this physical outward display all day, every day. And people have a hard time. If you're not touched by this, you have a hard time forgetting that this whole thing happens inside. You can't see it. You don't know what's going on. And the empathy just isn't the same as it is for someone with a outward physical, ailment.
To your point, and then to kind of pair that up with Dr. Kim, people actually applaud somebody losing weight. So how would I feel empathy for somebody that I admire?
You're doing something I can't even do, right?
Yeah, you're losing weight, and I think that's just so amazing. How can you be sick?
Right.
I wish I could lose that kind of weight. And that's really kind of this wacko mindset. And then the communications that go to the patient or the person that's suffering are, keep it up, continue to lose weight.
Right.
You're looking really awesome. If they actually start to put on weight and then family members say, oh gosh, you look like you're gaining some weight, you look great. What they hear is, I better stop eating because somebody just noticed that I'm gaining weight.
Right.
Yep.
Yeah, so not only can they not have empathy, they admire your weight loss.
Right.
And I think part of what's tricky about this all is I would venture to say that the vast majority of Americans have been impacted by a sick national idea about bodies and weight, and I think all of us in this country are to some extent or another impacted by thin bias.
For sure. Yeah. Now, can you define thin bias? Obviously, I know the two words and I can put it together, but for our listeners, when we hear terms like that, that tells me that people had to figure out the right terminology to explain a problem, right? Like, that's what I'd like for you to explain a little bit more. And we keep saying we'll come back to your history, but I think a wildfire has started. So maybe if there's a way to tie in, that I'm always interested when it gets distilled into a term that we can use. So what is thin bias, and why was it necessary to create an actual term for this thing?
Yep. So part of creating a term is, again, making it speakable, because it's something that's so pervasive that it's invisible. And I can tie it back to a piece of my story. That athletic director, when I was a junior in high school, made a comment about how much weight I had gained between my sophomore and junior year, which is, a comment rooted in thin bias. For me, my experience of that transition was I was weightlifting. My thighs were big and powerful and strong. I had a great vertical, nobody was pushing me around on the basketball court.
Right.
And for this male athletic director, he made some offhanded comment about a female athlete's body, a high school female athlete's body, that was rooted in thin bias.
Right.
Would he have said that? And also, potentially, I don't think he would have said the same thing to a male athlete that had put on weight, right? So there's a sexism piece to it as well.
Even if he did, would the male athlete have felt the same way you did? A male athlete might have said, "Oh, thank you. Yeah, I've been exercising, right?" I mean, to a male athlete, that might have been a compliment.
Yeah, for sure.
Well, and to men with eating disorders as well. Because a lot of times it's for men with eating disorders, the body dysmorphia piece and the body image dissatisfaction piece is around being too small.
So it's all about the gains,
Yeah.
the muscle gains. And I just find that so fascinating. You can have the same coach, the same statement to two individuals, and it is taken, and the effects of it are felt for decades, for a lifetime. The ripple effect. And one can take it as never think about it again, and the other one can set a course to their life.
Right.
And forgive the cheesy transition, but the course to your life, you've brought up this coach several times, and I've always heard this as someone who hasn't directly been affected by eating disorders. I've always grown up hearing that a lot of this starts from coaches and teachers just making an offhand comment. Like if you were to confront that coach and tell them what they said, they would never think in a million years.
They might not even remember what they said.
For sure. Chances are very good that they wouldn't remember it because it was just a quick observation. So can you pick up from when you got into college and you felt so out of place? This is my term. It sounds like you felt isolated from that world. Is isolation a part of this journey over time? Do you get separated?
Huge.
Okay.
Huge.
So pick up from college. You're feeling separated and isolated, and please continue.
Yep. So the isolation is also a huge core feature of eating disorders for most every person I've ever treated with it, which is part of why connection and community is a key piece of the healing process. But after my first attempt at getting help and being told it's not that bad, you only have like 6 more sessions or a very small amount of sessions.
Let's just get you through this work, and then I don't have to deal with this anymore.
Yep. I just went on, and it got worse and worse and worse and worse, to the point where I was in, it was impacting my capacity to play basketball. And I was still playing because I wasn't going to let, anything take that away from me. And I wasn't going to let anyone know I was suffering. I felt like I experimented with that. And the answer that came back to me was, not that, like, come on, you wimp.
Right.
It's
You're
not
an
that
athlete.
bad.
Yes,
Yep.
tall.
Get back out there. So I got back out there to the point where when I was in medical school, I was symptomatic every single day, many times a day, and couldn't make it through a day without experiencing eating disorder symptoms. It's an awful way to live, and I did not want to be living that way. I just couldn't. I didn't know what to do about it. I didn't know that there was any help. I got referred to a couple of people in Hyde Park, again, who had little familiarity with eating disorders. And it was really heartbreaking because I hated the idea of getting help. Just like, I'd done everything myself. It was part of my family culture. Like, don't ask for help, be strong.
Yeah.
And, one of the most heartbreaking memories I have in a therapist's office was when this therapist just looked at me with like despair in her eyes. Like, I really don't know what to say. Like, I hope you make it back here next week.
Oh, good Lord.
So
I just got a shiver. I mean, really, what a horrific thing to say. You're really in such bad shape. I hope that you survive.
You can feel the despair just sitting in, Yeah.
Yeah. So, and at the same time, in college is when I had my first drink. I was very like anti-alcohol, all through high school, and very indignant and self-righteous about it too. So
That's nice.
any of my family members who drank or teammates,
Sure. Oh yeah.
they knew how I felt about it. But my family ended up intervening on New Year's Day of 2000 after an episode very early in the very early morning hours, and suggested I get some help. And I started working with the therapist who knew addiction and knew eating disorders. He had helped my sister actually many years before. So I was a little bit more comfortable with the idea of going and seeing him. And, even with him, I was seeing him 2 or 3 times a week, and it took probably 3 months of seeing him before I shared with him what I was doing with food. Because the shame was just so deep about that. And another piece of it for me too was the money I was spending on binge foods. Because, this was student loan money. It wasn't like I had access to, extra resources
Right.
for anything.
Right.
Yeah.
But this therapist was really crucial in connecting me with a support network. He suggested appropriate levels of care, which I refused because I was a medical student and there was no way I was
know so much more than this. Yeah.
Yes. But I finally got connected with groups. I got connected with a nutritionist who really, and the piece about a nutritionist too is I was doing lobby day with the Eating Disorder Coalition last week on the Nutrition Care Act, which wants to mandate that all Medicare recipients have nutrition therapy covered if they have an eating disorder, which is not covered right now. And one of the congressional staffers said, well, don't people know what to eat? Why do they need a nutritionist? And I think that speaks to how difficult it is for people who don't understand what it means to have a brain disease, a disease that affects the organ that we use to, dictate our behaviors. That it's just a really hard thing to understand if you've never felt it. But it helped when I said, well, what do you think? Do you think people who have had several opioid overdoses know that it's not a great idea and that they might die if they continue using opiates? Like, don't you think they know that, like, not using opiates would be a healthier way to go? She was like, yeah, that's a good point. So it's similar.
Yeah.
Yeah.
So it was really helpful having that out of my hands and into the hands of a care provider that I could trust, who helped me learn how to feed myself as a medical student, right?
I wanted to ask you another question, just kind of a follow-up to something that Patti and I have talked about with several other guests. When you have early experiences with getting help, early experiences with therapy, early encounters, and they go kind of south, they go kind of sour, they're not great. In any range from, it wasn't great to, oh my God, I'm never doing that again. Did you find for yourself that it made it harder to find help? Did it make the healing process even harder? Like, it's made it feel like it was further away? Or... Yeah. Okay. I just didn't want to put words in. Okay. Could you unpack that just a little bit? I don't want to take a lot of time on that, but this is one of those themes that keeps coming up. People who later on found help in the early days, the discouragement, and what kind of advice would you have for someone who is about to go in and have their first or second or third encounter and they're trying to trust this person? Can you kind of unpack that a little bit?
For sure. It's such an important thing because it felt like a death sentence to me. First of all, like I said, where I came from, we didn't ask for help. It was a sign of weakness. And I was strong. Like, I needed everybody to know that I was a tough guy, even though I was a woman. And I am tough, but there's a whole lot else to me, right? Sure. But constitutionally, asking for help is something that I think is difficult to begin with for most people who have the characterological makeup that goes along with having an eating disorder. So when you take the risk and show the vulnerability to ask for help, and it's met with people who can't help you or people who tell you you actually don't need it, which, by the way, is the message that all of our patients who get insurance denials get. Like, it's not really that necessary.
You don't need the help.
It's not that bad.
Yeah, that's good.
There's nothing quite like that to invalidate suffering that you're already feeling shame about. So it took me, and I went through probably 4 or 5 different therapists, 4 or 5 different attempts to get help, which felt like Herculean efforts.
For sure.
To even walk through the door.
Yep.
So, by the time my family intervened, I had already surrendered to dying of bulimia, in my 20s.
Wow.
I was pretty sure that it was just going to kill me, and suicide kills up to 50% of people with eating disorders. The other 50% is usually medical complications.
Right.
And the disease robs you of so much that, at some point living in that way, the thought of dying from it felt kind of like, okay,
Right.
so I was at a place of like, if this is going to kill me, like, I'm okay with that, because the way that I was living was just so painful. So when we have patients walk through our door who are treatment naive, my staff all know that, like, this is a very, like, precious moment and a delicate moment and a sacred moment. If we don't think we can help, based on, like, we don't have a staff member who has deep expertise in ARFID, avoidant restrictive food intake disorder. If we have a patient who walks through our door who has that, I don't want to pretend like we can treat that with a depth of expertise that we don't have. And I also don't want to give them the message that, well, this is something bizarre, like, good luck with that.
Right.
We want to do a warm handoff to an expert that we know in the community that can help this person. So, and I tell patients all the time too, like, your only job is to keep asking for help until you find the help that is uniquely equipped to help you, because I know it's out there.
Wow.
And it
Advocating.
might take 5 times or 10 times.
Yeah.
Your only job is to keep asking and to keep searching.
What would you suggest? I mean, we have a pretty wide audience. The therapists, the people, the parents, the coaches that are watching this, inevitably at some point will have somebody in their life with an eating disorder. They probably already have and possibly didn't even notice it. Maybe they've already been in this situation and they possibly blew it. What is the right response when you don't know how to help? And I don't know if it's right or fair to even ask you that question, but for that therapist that's sitting there, that social worker, and then, for them, they're completely caught off guard by finding something like this. Typically at the level, by the time someone is willing to communicate it, that level's pretty advanced, I would think. What's the right way to say, I don't know how to help you, without it activating? I try to use activating instead of triggering these days, without it activating something inside of that person.
I like that you use activating instead
I have to find new terms. I do it all the
Some of
time.
these overused terms are like, oh, I'm so past that.
It's my full-time job finding new terms for these things. So thank you.
First of all, that's amazing. Okay, so the right way to respond is, this is serious. I am so incredibly grateful that you're sharing it with me. That's really brave, and I know that's not easy. And I am going to be with you until we can find somebody who is trained to help you, because those people are out there, and there are a lot of them, and then you go into your professional network. If you don't know anybody who's an eating disorder professional, call the National Eating Disorders Association, call the Alliance for Eating Disorders Awareness, call the Academy for Eating Disorders, call ANAD, the Anorexia Nervosa and Associated Disorders Association.
A lot of good resources there.
Yeah. And I love that your answer and your approach it gives hope. Like, this is serious. The right people are out there. I'm not necessarily that person, but I'm going to make sure that you find them.
Yeah, important not to
Right,
minimize.
and not, here are some options, see you later, but I will be right here with you. We can call these people together.
Yeah.
I'm with you, and I'm going to get you connected to help that can actually make a difference in your life.
That's a great answer.
We talked a little bit about this, but now might be an appropriate time to segue into it. The unique nature of each individual's personal situation. Yours happened to be alcoholism and bulimia. When you first had the family intervene, Was it for both, or was it primarily for alcoholism or the other, bulimia?
Yeah. So, that's another unique thing I think about eating disorders is many times they're so hidden. Like I wasn't going out and binging and purging with other people ever, but my drinking was very public,
Right.
And so they just knew that I was suffering, because I had gotten into a fight with one of my older brothers, and they were like, I think maybe you need some help with, some of the family stuff and maybe drink a little bit less, so it wasn't like, oh my God, you're dying of an eating disorder. But that was probably, the combination of eating disorder and substance use disorder is very deadly. But they didn't know, they didn't know about the eating disorder piece. And when they did find out about the eating disorder piece, they were really, really afraid.
So when people have comorbid issues, how is it best to approach those situations? Because eating disorder alone would probably be different than eating disorder and substance abuse. And then what about the other mood issues that wouldn't necessarily go along with substance abuse, anxiety, OCD, other psychological concerns? How best to communicate or address, or what do we do next?
Right. As a non-professional, is that what you're asking? Like, not someone who has the skill sets. Someone like me. Yes. Yeah.
Yeah. So I think this is part of why a thorough diagnostic assessment is important, and when possible, treat holistically, by which I mean treat co-occurring disorders in an integrated way. At the same time, with the same set of treatment providers. If that's not possible, and unfortunately in our healthcare system today and in the eating disorder world today, and even in the addiction world today, it's very siloed. Mental health care, medical care more broadly is very siloed. As a psychiatrist, to people with multiple medical disorders and multiple mental health issues, it's shocking how non-existent communication is from one doctor to another. And also the most dangerous part of that for my patients are most medical doctors know nothing about eating disorders, get very little training in their medical school or residency programs, and can oftentimes say things and make interventions that actually make eating disorders worse. So that's I feel like that's a whole nother talk, but when possible, treat co-occurring disorders together at the same time. Our healthcare system in mental health is set up to sort of tease people apart, like, okay, well, what is primary? As a human being, our patients are waking up every day with their whole set of issues. They're not just waking up with their eating disorder because that's what insurance feels like is primary. Right. They still have their PTSD, or they still have their, depression with suicidal ideation, or their OCD, or their addiction. And far too often what we do is we send people to, well, you're going to do your eating disorder treatment first, and then you can go do your OCD treatment, and then you could do your, Ativan addiction treatment later.
Right. Right.
And all the while you have to figure out how to put that all together for you as a person, with little.
Doesn't exist in any other industry. I mean, if someone told me I had to do that with my car, I had to go somewhere completely separate for every aspect of my car, and then none of those mechanics are ever going to talk to each other. It doesn't even make any sense. We've just gotten here by reverse engineering from the way the money is generated with insurance. And now we end up in a position that doesn't make any sense to the human condition. It it doesn't connect. And the teenagers that I used to work with that had eating disorders in particular felt so lost and so distant. They just felt so isolated. That's why I knew to reference that. The idea of trying to find help in that system that we're talking about makes it unbearable. It makes it seem so impossible that not only do I have this thing that's happening inside of me and nobody understands it and I'm alone, but now I have to go find the right resources, connect. I don't know who would have that, and to your point, all while the brain is not operating the way it's supposed to be operating. Like the very organ that's meant to help solve these kind of problems is under attack.
Yeah. Right.
It's horribly dark.
And even for family members who are often the ones out there, dealing with insurance and trying to find the right program, like they're under an incredible amount of stress with, coming to the realization that their kid has a potentially fatal illness.
For sure.
They don't have, they're not operating at, their baseline either in those circumstances.
Right.
Do you have any words of wisdom for the patients or family or loved ones because of all of this silo mentality that is going on there? I know that could be a whole nother talk, but if there's any word of encouragement that we could leave the listeners with before we move on, I think that it would be appreciated. And I'm sorry to put you on the spot if it's something that really isn't easy to describe, but how do we help patients and family members advocate for the very patients who are struggling and not getting insurance coverage or getting doctors that don't even know what an eating disorder is, or what kind of advice? Yeah.
Well, one piece of advice that I give families and patients all the time is if something doesn't feel quite right about the treatment that you're getting, or if you don't feel like you can actually trust the doctor that you're working with, that's important. That too, you need to speak to your family about that, speak to your team about that. Oftentimes patients will work with doctors and there's an intuitive knowing.
Right. Yeah.
I knew, for example, when I went to my therapist who saved my life, I knew the first time I went to this person that he was somebody who could help me. It was just a felt sense. I didn't know anything about his therapeutic techniques. I didn't know anything about, what he did, other than I knew he helped my sister and I knew that he knew addiction and eating disorders. So I say to parents, I say to kids, I say to adults who are in treatment, if something doesn't feel quite right, pay attention to that and talk about that, and keep, stay on the search.
That's really important. That's a real good point. Mm-hmm. Do you want to touch on the fact, something that you said earlier, that you had visited this particular therapist, I don't know if you said how many times or how many weeks before you even brought up what you were doing with food? I think that speaks to the point that you were willing to talk about all of these other subjects, and yet out of all of the shame-based issues, eating disorders was still way far back there. It's still not something you could talk about.
Yeah. So before our first session, he asked me to make a list of what I wanted to get out of therapy. And I probably wrote 5 or 6 things down on that list and read it to him in our first session. But it was, I was testing the waters.
Right.
So what was on that list? Stresses of medical school.
Right.
Really vanilla,
Of course.
Yeah, right.
Non-stuff stuff.
Yeah.
But it took a good 3 months, maybe 4 months before I even shared a little bit with him about my eating disorder. And when I did start to share with him, I certainly didn't share everything that was going on.
Sure.
It was like, well, every now and again, this thing happens with food. It wasn't.
Speaks volumes, Kim. Seriously,
Yep.
that is pretty remarkable. 4 months, and even though from your first visit you felt like this person could help you, from the first visit you felt like you had this trust that you could place there, I think that is not insignificant that
No.
somebody waited that long before they could talk about the last subject. I don't know, was it your last subject? Maybe not.
Yeah. Yeah. I mean, it was low on the list.
Right.
There were other subjects beneath it, but
But it's interesting. We keep coming back to this point because the more negative experiences you've had, it adds to that runtime of earning trust.
Right.
So, in another person that we were interviewing, Gloria, we were talking about how people who experience trauma when they were children, they subconsciously they learn how to like plant opportunities for you to show that you're not trustworthy, right? Like they'll just put little, I call it bait, they'll put something out there to see if you're going to jump on it and be super critical or if they're super judgmental. And that's a learned thing specifically from childhood trauma. Like you learn to poke the bear several times before you put your hand in its mouth. And the more negative experiences you've had, now, if that's a kid who, and I always want to be careful comparing trauma, but if you're talking about a kid who's gone through a bad divorce, that's one thing. But if you're talking about someone whose brain is literally being devoured, for a lack of a better term, from a disease, it's the timetable that has always been a concern with me about eating disorders. As a total outside to that world, there are other issues that people deal with that, if it keeps getting pushed down the road, their life is not getting better, but it's not as dangerous as something like an eating disorder. So every time somebody goes and has a bad therapy experience or a bad help experience, we're really pushing that timeline dangerously, like redlining that timeline. And this is something that Patti and I keep talking about is where can we, with our resources and our organizations, focus on removing and helping alleviate the sense of shame. We're not doctors. It's not going to happen. We will not be joining you in any of that. However, we have the ability to help people, and I know other listeners want to help people, and it seems like shame is this ginormous beast that's around this. And every time somebody has a bad opportunity, because it takes so much courage to go present yourself to a total stranger and tell them your darkest secret, every time I feel like that shame is like compounding and it pushes that person even closer to a horrible end. So my question in all that is, one, is that true, or is that just assumptions that I'm making, that bad experiences escalates the problem? It's not a neutral thing. It's making it worse. And then two, what can we do around the shame aspect about this?
Yep. I'll start with the second one. I think what you guys are doing here helps tremendously with the shame aspect. People need to hear about these illnesses. People need to hear about what they look like. People need to hear about treatment that works. People need to hear about people recovering. People need to know that it's not a patient's fault for having a disease. A lot of times patients will say, this comes up a lot more with the in the substance world, but also in the eating disorder world. Like if I have a lapse into purging, am I going to be kicked out of treatment? Or if I can't finish my lunch, am I going to get I'm so sorry I didn't finish my lunch. When a patient says that to me, I say, let's just take, the moral world and put it over here for a second.
Yeah.
And I'm a doctor. I'm here to help you. It sounds like you're having symptoms of a disease that I've been trained to treat. So why are you apologizing to me for having symptoms of a disease which is hurting you? That doesn't hurt me at all. I ate my lunch. My brain is nourished right now. You're hurting, you're suffering. I'm here to help you. And I think if, the more people understand that this is not something a person's doing because they want to be doing it. I have not met one person who says, yeah, when I was 5, I had this dream that someday I'd end up in residential treatment for my eating disorder.
Right.
And that my family would spend hundreds of thousands of dollars out of pocket, that could have been going to my college to pay for medical care. Nobody says that.
Right. Right.
You know?
Which, to your point, that should make it obvious that this is not something people are choosing. This is not the way that you go about getting attention.
Yep.
But I used to run into the same thing where children who were having suicidal ideation, their own parents would be like, they're just trying to get attention. And it just takes your breath. You're like, no, man, that is not how people go about getting attention. And it's scary, the dismissive nature. But I do think after working with so many of those parents, the dismissive nature was rooted in just fear. It's almost like they can't imagine anything else. Yeah.
It's a defense mechanism.
For sure.
And your first question, does having bad therapy experiences compound the shame and push people further away? For sure. And it's a complex issue, right? Because there is this capacity when you've had trauma to experience reenactments, so if you went to your family of origin and they weren't able to help you for whatever reason, it's sort of the frame that you approach authority figures with, whether they're therapists or doctors or coaches or whatever. And it's easy to live in that frame even when it doesn't necessarily match the reality of today.
For sure.
But that's part of what we know as therapists and doctors when treating people with histories of trauma. And we can speak to it, and that in and of itself engenders some amount of trust and can help people.
So, Kim, we've spoken quite a bit about personally having an eating disorder. Let's go forward a little bit and talk about your professional life and how you can help people and people who are in need of therapy or help. Talk about how you got to where you are and what you do as a professional.
Yep. So I did all of my training at the University of Chicago. So I went to medical school there. I went to college there. I went to medical school there. I did a year of research there. And the year that I took off from medical school and did research is really when I got into recovery. And I would say, the eating disorder symptoms of binging and purging probably took about a year and a half of intensive outpatient therapy before those, and robust community support multiple times a week. People that I could call 24/7, and a family who was able to make dinners for me and support, my mother fed me. And as I was a medical student, it was kind of nice to be able to, drive home from the University of Chicago and not have to worry about feeding myself. But God bless and may her soul rest in peace, my mother, for, doing that for me and loving doing that for me. Very, very grateful for that. I know not everybody has that. And I'm really, really blessed that I did. But, it took a lot of time and a lot of support, bottom line. So I did a year of research while I was getting myself into recovery, and probably 3 to 4 years after being in recovery, I felt like the disease had been lifted from me, and gone from my brain. And every morning I wake up, I am so grateful for that. It's a gift and a blessing, and I do not take it lightly. So I did my residency. I was planning on being a schizophrenia researcher, but I had a mentor who was running our residency a process group for our residency classmates for all of the years of residency. And he actually shared that he was in recovery from an eating disorder. And that was the first time I had ever experienced any other doctor talking about having been sick with anything and having recovered from anything. And that made me feel like it was safe to share that with my colleagues that, hey, I'm in recovery from an eating disorder too. So even being, in recovery, I was still walking around like I was like there was some shameful secret that I couldn't let my medical colleagues know. Even though it had been like 3 or 4 years since I'd been symptomatic. This mentor really supported me in like being open to working with eating disorders and addiction and mental health that was not schizophrenia. So right out of residency, I was hired by a residential that was set up to help adolescent girls with eating disorders. Before they opened, it was probably 6 months before they opened. And that was a really amazing experience to be able to come in at the ground. I was the only psychiatrist there, and really build a program from the bottom up. Yep. And that, for a big period of time, there were like golden days there where the team was amazing. We were doing amazing work, powerful work. And more money came into the place was bought, the place continued to grow, bigger and bigger and bigger and bigger. In the meantime, the field in general was being flooded with private equity money, which sort of decreased the pool of eating disorder expertise that was available out there to work at places like I was working at. And I was also finding myself being very bothered by patients coming to our center for residential care, getting good care for a month or a month and a half, and then going back to their home state and not really having access to care that could treat them comprehensively and in an integrated way, and then coming right back. 6 months later, coming back with the same, so it started feeling like, wait a minute, I don't think we're actually, doing, making good on the investment of time and money that these patients are spending here with us. So my husband and I decided to open our own place, and we co-founded SunCloud Health with the idea that we wanted to eventually be able to offer a range of levels of care, but continue to hold people long term and support people long term. Not hold, hold in a therapeutic way, not in a you're ours.
Detain.
You're never getting out of here.
Yeah.
I would hear the word hold and be like, red flag.
Mm-hmm. Yeah, no thanks. Yeah.
Yeah, but to be able to continue to support people outside of acute episodes of care, because that's where the hard work is. It's easy to help somebody in a residential level of care. The hard work is when they return to their families or when they return to their homes and their spouses, and they're in the day in and day out of their lives. So how do we make this sustainable? How do we be the preventative care arm when they have to go get their colonoscopy when they turn 45? Hey, you're going to have to not eat for a day. Do you think that's going to trigger anything for you? Because if there isn't somebody who's saying that to them, I guarantee you it's not going to come from their GI doctor or their primary care doctor.
Sure.
That's true.
So there, it's a, and I also really like having sustainable, long-standing relationships with patients. And that's, that too is healing for a lot of our patients who have attachment traumas, who feel sort of like they've done program hopping or hopped from this person to the next, to the next, to the next. So It's been 5 years now, going on, 5 years now, and it's been a lot of work, but also a really beautiful experience to be able to handpick clinicians, to be able to have total control.
Yeah, I bet.
Yeah, that's wonderful.
Which we never really have.
Sure.
You know.
Sure.
Yeah, it's an illusion.
But
We like to think we do.
Yep, it is an illusion for sure. But it's been I look back in amazement over the last 5 years. I thought my husband was crazy when he was like, let's start our own place. He's a business guy, an entrepreneur, and I'm a doctor and like things, pretty like well planned out.
Yes, entrepreneurship is nothing but
Yeah.
well planned out.
Yeah.
Absolutely. I want to be sure that we talk about a subject that I realize is very important to you, and I want to give you time to speak to it. There is a stereotype that eating disorders primarily hit North American white high school and college girls. You have some work in other areas, specifically chronic, as well as people who are going through menopause or who develop an eating disorder when they are older, and then also men. So would you talk to some of the groups that are not the typical stereotype?
Yep.
Do.
Yeah. So that's a pervasive myth, right? That these are diseases that affect like middle class, upper class, white adolescent girls. They affect all different races. They affect all different genders. Men and boys are highly underserved, primarily because so much of the eating disorder, the vast majority of the eating disorder research has been on women. And all of our diagnostic tools, all of our screening tools, have been largely designed and researched and shown to be efficacious for white women and girls. So there are lots of efforts right now going on to adapt and create tools that will help people who are not in the majority. So men, boys, Black people, brown people, gender minorities. And one of the things that's been really, really great for me personally and professionally is to run men's eating disorders groups. And to work with people who have another area that I think it's highly stigmatized within the eating disorder world. Two areas. One are those with chronic disease or relapsing and remitting courses. There's this like, if you're not recovered, then there's something wrong with you. That's never what people say, but if we step back and look at, what every advocacy group sort of highlights, it's recovered people, but we know that up to, 20 to 30% of our patients, we don't have good tools for. So we are still failing 20 to 30% of our patients. And those patients deserve good care, and deserve to be celebrated and highlighted for their wins, even if it doesn't look like what my win looked like or what somebody else's win looked like. So those two patient populations are populations that we serve and we delight in serving. The men's group, I love my men's group. They're amazing. A range of ages, a range of different professions, range of, unique diagnostic clusters, that just aren't the same for every single person.
Yeah.
When we talked about this the last time, you mentioned that there were things that you learned from them, not just ways that you could help them through whatever their progress was. Do you want to speak to that any?
I've learned so much from them about all of the, again, these embedded ideas in our culture about what it means to be a man, beyond just body and food. So many, a big aspect of what all of the men I've treated with eating disorders struggle with is this, they battle with this idea, I have a girl's disease, like, what does it say about me? So there's an added layer of shame. And many of them have been in treatment that perpetuates that, not intentionally, but by virtue of the fact that they're the only man in the treatment group.
They can just look around. They don't have to be told.
Environment,
Yeah. So I think it's important to be able to offer treatment to people who have identifiers that are common, that are not just like anorexia, So do I really want patients coming here and identifying as, well, there's the anorexia group and there's the bulimia group and there's the binge eating disorder group?
Right.
No.
Yeah.
I want people coming and identifying as human beings, and identifying with aspects of who they are that don't really have anything to do with the disease.
I've heard that theme quite a bit from patients directly. I wish somebody would treat me as a person and not as my illness. And I think it's important that we continue to repeat that to people who haven't personally experienced that, because it is almost a default role. You focus on what it is that they are there to be treated for.
Sure.
So. Yeah. Well, and that, one of the things that I always get on a soapbox about is when I hear professionals using words like, she's an anorexic or he's a bulimic. Right. Like this is a person, or even say this is a patient with the disease of anorexia, or this is a patient with bulimia, or anorectic is even, I don't know why, but that whenever I hear a professional use that word,
I didn't even know that was a word.
It's an old school word that many of the old school eating disorder professionals still use.
Okay.
It sounds very permanent. That's the issue. Like, this is what you are.
Right.
Yeah.
We don't look at you and say you are cancer.
Right.
Not more than once.
Right.
Say it. You're only going to get away with it one time, and someone's going to be like, I'm sorry, what?
Yeah. You are broken.
Yeah.
We just don't. Yeah. So I think that's a good message to get out.
Would you ever say to someone, this is a breast cancer?
Right.
I'd like you to meet this breast cancer.
Yeah. Very awkward meeting.
Yeah.
Very awkward.
Right.
All righty. And my name is. Hello.
Right. Right.
Could we
would never even ever say that.
Yeah.
But
right. Right. Okay, so stop saying that, people.
Yeah.
Listen up.
Yes.
Yeah.
But that does speak to the fact that it does feel like it has always, for me, as an outsider, totally untrained in this space, it has always felt like the majority of parents felt like their kids were choosing this. When I was working with parents, full disclosure, when I was a minister and a youth pastor working with kids is what I'm referencing to, it feels like the fact that we don't do this in any other disease, we do it with this, is one more thing that points to the fact that it's almost like it's something you're choosing to do. It reminds me of like the abusive way that parents used to deal with bedwetting. Like, you're a bedwetter. That's what you do. And kids grew up with incredible, horrible issues as a result of just parents just shaming the daylights out of their kids. Again, it just seems like we would never say this, hi, this is cancer, this is breast cancer, but this is an anorexic. It just seems like that we feel that way culturally, as if people are choosing. Like they really are, at the end of the day, if this is horrible to say, I'll even cut it out, but it does feel like there's part of our culture that feels like people are like, yeah, they're choosing this. This is something that they want.
Absolutely.
Yeah.
I still meet people to this day who are very intelligent, very well educated, very socially aware, well-traveled. I mean, these are not people in an isolated, don't go out of their hometown, who believe that this is a choice.
Yeah.
We've just got to say that it is not a choice.
Right.
So. Yeah. And I think, the other area of mental health where we do hear it is this person is an addict or a substance abuser.
Right. Good
this
point.
This person's an abuser.
Yeah.
Rather than this is a person with a disease of addiction. And then schizophrenia. Like oftentimes people refer to people with schizophrenia as this is a schizophrenic.
Sure.
Yeah.
Sure.
Right.
You're totally right.
It's interesting, though, the ones that you've identified, if I've caught them all correctly, are not primarily the medical problem. They're primarily a behavioral or a mental health problem. So we're still getting that issue between, we've figured out that because somebody has a medical disease known as cancer, we talk about them differently. But anybody with a mental health concern, we feel like it's okay to identify them as their problem.
Right. And I really think like one thing that would help a lot with this is if we started talking about brain diseases as medical illnesses that affect the organ called the brain.
Exactly.
Like mental health is a medical issue.
It is. Thank you.
But it's been carved out, which is part of the stigma. Like, get those people over there. Don't put them in my camp. Right. Like, this is a real issue.
Right.
And those are made up issues. And I think, neurobiologic research, genetic research is really, we can't look at that research and what we know today and say that these are not medical illnesses.
Right.
Well, at the end of the day, when people are dying, they are dying from medical problems associated with this illness.
For sure.
So if that isn't a medical illness, how is it defined?
Yeah.
People die of organ failure. They die from all sorts of medical issues associated from this. I want you to be able to tell people how to get in touch with you. Talk about, you've got a new facility that is opening up soon. Speak a little bit about your company and how people can connect with you.
We're going to have beds.
Yay!
I'm really excited about that. Small, reasonable, something we could do well. So we're SunCloud Health. www.suncloudhealth.com is our website. Our phone number is on there. If you want to reach me, my email is probably the best way. Dr. Kim at suncloudhealth.com, and that's just DRKIM at suncloudhealth.com.
Awesome.
But we offer outpatient, ongoing outpatient care for people who have been through our IOP, PHP, and soon to be residential.
Kim, can you explain those letters for the listeners who don't know?
Oh, yeah.
For me.
IOP
Sorry.
and PHP.
I heard IHOP in there somewhere, but I wasn't sure.
For pancakes.
Yeah. All right. Pancakes.
So we offer intensive outpatient treatment, which is anywhere from 3 to 5 days a week, usually 3 or 4 hours a day.
Okay.
Partial hospitalization program, PHP, which is full day treatment, Monday through Friday. And then residential will be 24/7 care.
Gotcha.
That is very informative, and it's actually very exciting, too. Congratulations on this new opportunity for you. And you are located where?
We are located, our main site is located in Northbrook, which is where our residential will be, Northbrook, Illinois. And then we also have a site in Lincoln Park, which is in Chicago, and a site in Naperville, which is a southwest suburb.
Perfect. Well, thank you very much. It has been wonderful talking with
Absolutely.
you today, and we are very happy that you could join us. And I guess that's up to you then.
Absolutely. Well, listeners, thank you so much for listening. We've covered a lot in this particular episode, so feel free to ask questions or make comments wherever you happen to be listening. Check out channelsofhealth.com. I'm always trying to not say channels of healing. That's why there was a delay.